Hello. Today we discuss about which progesterone may be better for a frozen embryo transfer, and this was a paper in Fertility and Sterility where they put a commentary on the systemic progesterone in frozen embryo transfer and understanding the roots. So, if you go at it from a definition of the importance of progesterone primarily is secreted by the corpus luteum and plays an important role in preparing the uterine lining. It supports the early pregnancy by stabilizing the endometrium and preventing uterine contractions, thus maximizing the chance for a successful pregnancy. From a historical perspective, progesterone have been given in reproductive medicine since assisted conception started. Initial applications included treatment of women with ovarian failure, evolving to a more refined use in protocols and fertility treatments. So, what's the role of progesterone in reproductive technologies? In assisted reproductive technologies, systemic progesterone is fundamental in enhancing the endometrial receptivity and ensuring successful implantation. Studies indicate that maintaining adequate serum progesterone levels is vital for optimizing outcomes in frozen embryo transfers, particularly in the context of low serum concentration. When you look at the administrating methods, intramuscular has been used for a long time, historically being the standard for luteal phase support in assisted reproductive technology. It is it consistently maintains high progesterone levels, leading to improved outcomes in frozen embryo transfers. You have vaginal progesterone, which has again been used for a very long time. It's known for its high local uterine concentrations, offering a patient friendly alternative. However, comprehensive studies suggest while effective, its success rates may be lower to IM progesterone in cases with low serum concentration. Again, a big question mark. There's still studies going on, and there's been a question mark on this aspect. Subcutaneous progesterone has been used and has been extensively used and represents a promising alternative. It tends to combine the benefits of high endometrial concentrations along with a more comfortable way of offering the treatment. So the choice now comes between intramuscular, vaginal, subcutaneous, depending on a patient's specific factors, preferences, and clinical context. Understanding this becomes extremely important. So, for the clinical evidence, let's look at the current evidence. Recent studies indicate that systemic progesterone administration optimizes outcomes for frozen transfer. Randomized controlled trials indicate alternative routes such as subcutaneous as well as vaginal have shown effectiveness. The gold standard still remains IM administration for achieving very high progesterone levels. It tends to be a level 1 evidence of intramuscular progesterone continues to be backed by level 1 evidence as the most effective method for luteal phase supplementation in ART. So if this paper suggests that studies demonstrate that it gives you optimal high serum progesterone concentrations and whether if that's a link, then certainly it gives you a much better chance. When you compare IM and intramuscular and vaginal, some studies do indicate that vaginal progesterone concentration tend to be higher with vaginal progesterone, but intramuscular progesterone seems to go with a slightly higher chance of systemic absorption. From a future directions, I think subcutaneous is something which is going to be of much use, and it's something which we look forward to in multiple studies. At present, multiple clinical trials are ongoing. For implications of clinical care, we would suggest that the integration of looking at subcutaneous as well as combining it either with intramuscular and vaginal, and combining the vaginal route with any of these may be beneficial. So that's general in looking at the paper. My general view is that until we know there is no harm in a frozen cycle keeping your progesterone levels high, that in fact may give us a much better chance of pregnancy. Until new research is due, that's what I tend to